So, sir, it's 3, 2, 1. Over to you, sir. You can start the session.
Thank you. Good evening, everyone, and thank you for joining us today. My name is Dr. Shailesh from Lupin's Medical Services team, and I welcome you all to this interesting webinar series called of today's discussion is, and to present this topic, we have with us a very distinguished faculty, Dr. N. Arun. Welcome, sir.
Thank you.
So, Dr. N. Arun is an eminent consultant in gastroenterology and hepatology, Chennai. He has completed his DM in gastroenterology from Stanley Medical College, Chennai in 2018. And he has also worked as assistant professor in medical gastroenterology at RGGH, Chennai. Currently, he is working as consultant gastroenterologist, hepatologist, and interventional endoscopist in Apollo Mains Hospital, Chennai. He has also has a distinct inclination towards research, which led to several publications in international and national journals. He also had the opportunity to give his presentation in different conferences. So with this brief introduction, I welcome Dr. Arun sir to present the topic. Over to you, sir.
Thank you, Doctor, for a wonderful brief introduction. Respected professors, senior consultants, and my dear friends, it's indeed a great pleasure for me to join in this Monday evening at around 8 p.m. to discuss about one of the most complicating scenario, most complicated area, day-to-day practice, right from a pediatrician, right from a surgeon, right from a physician, right from a gastroenterologist. Day to day, we'll be encountering this clinical presentation. And without that, our OP will be incomplete, because how to tackle this scenario is one of the most challenging for all the gastroenterologists, even in day-to-day practices. That's nothing but constipation. When you're going to look into that area, it will be highly constipating to discuss about the scenario. So how are you going to tackle a patient who presented to us in the background of chronic idiopathic constipation? Before taking on the discussion, I would like to thank Team Lupin, who gave me an opportunity to be in this discussion, which is happening pan-India right now. So my agenda today to discuss briefly, classify, approach, and management, and what are the recent updates, and before we are going to wind up, what you're supposed to remember in the management of constipation. It's a commonly encountered in your clinical practice. Mostly it'll be having a high negative impact on your quality of life. Once the patient is having constipation symptoms, if you're going to put a patient on medication, after that the patient won't respond, and the patient will have further worsening of symptoms. Sometimes the patient may have diarrhea based upon your medications. You may go for various challenges of laxatives, sometimes by a powder formulation, sometimes by syrup formulation, and sometimes by by a tablet formulation. We will be going for various dosage regimens, diet, lifestyle modification, all those things will be taking on. But even after that, most of the patient will be landing up with multiple issues. Some patient will be having side effects because of the medication. So it's very challenging, even for the best of gastroenterologists, to tackle a patient with chronic idiopathic constipation. So the mechanism is not fully understood, and not fully understood, and mostly it's a chronic condition. And still as a gastroenterologist, we need to learn this aspect of management daily, day-to-day practice. So what is the basic definition when you're going to look into this? So about a patient will present to us in the background of chronic constipation is any patient who's going to have hard stools, who presented to us in the background of excessive straining along with bloatedness, with infrequent bowel movements. The normal bowel movements in Indian scenario at least should be 12 to 14 stools per week as to can happen. But in this kind of scenario, if the bowel movements, if it is going to be less than 3, there is high possibility. And always you need to remember that one thing, the digital manipulation, use of digital maneuvers whenever you want to expel your stool, there is high possibility for the patient to land up with a defecatory disorders, a dyssynergic defecation, other problems may be there to take on with this kind of presentation. So the commonest event will be excessive straining, more than 50% of the population. Hard stools will be there around 40 to 50, and inability to have a proper bowel movement will be around 30 to 40% of the population, as per various definitions. If you're going to look into the normal stool weight should be around 200 less. So, but in Indian scenario, but in globally it can go even up to 311 grams. So that's what being discussed. So there are various guidelines being quoted based upon Indian Journal of Gastro or European Journal or by American Journal of Gastro, in which the 2014 guidelines been taken on with constipation. Now by 2022, a new guidelines been launched by ACG, in which IBS type C, irritable bowel syndrome, type C predominant syndrome, various molecules been tried, which will be having a beneficial role, is there or not. Well, there are multiple guidelines, even Korean guidelines are there. The most important thing we need to define by ACG is a unsatisfactory defecation, which is characterized by infrequent stooling and difficult stool passage or both. So then in this, if you're going to look into the commonest presentation would be abdominal pain and bloatedness and incomplete evacuation of your stool and straining during bowel movements. All these things will be having a characteristic maximum presentation. So if you're going to look into the basic classification of functional GI disorder, it will mainly take on by a Rome classification. Now the Rome 4 has been taken on from 2016 onward. So initially the Rome 1, Rome 2 and 3, now they have been categorized as functional constipation, diarrheal events in which IBS preponderant is whether it could be a mixed or constipation or diarrheal preponderant event, along with evidence of bloatedness, along with evidence of distension of abdomen. So in which the basic definitions of Rome 1, 2, 3 been consequently been revised. Now when you're going to look into the Rome 4 criteria for defining the functional constipation. So any patient who is going to remember this few points, very, very important to remember how are you going to differentiate IBS-C, chronic idiopathic, defecative disorder, all those things based upon the Rome criteria. You should know the functional GI disorders, how are you going to categorize. So more than 25% of the defecatory mechanism, if you are going to strain, the lumpy stools will be more than 25%, and incomplete evacuation more than 25%, and anorectal obstruction more than 25%, and when manual maneuvers, if it is going to be more than 25%. And what is going to happen? The criteria is going to fulfill over the period of 3 months of symptom and onset at least 6 months prior to diagnosis. So that's the main area for us. So there should be at least 2 criteria should be there to diagnose this Rome 4 event for the diagnosis of chronic idiopathic constipation. So straining, as I discussed, the same presentation, straining, lumping, incomplete evacuation, obstruction, and all those things, along with the low stool should rarely be present without the use of laxatives, and insufficient criteria for your IBS to met with. That's the criteria to diagnose your functional constipation. As I discussed, over a period of 3 months, and symptoms should onset at least 6 months prior to your diagnosis. The most important task force criteria by ACG, what I mentioned, the same scenario, either by unsatisfactory defecation, mainly by infrequent stooling, difficult stool passage, or both. These 2 pointers to be taken into account. And what is the difficult stool passage? It could be by straining, or it could be because of difficulty in passing a stool, incomplete evacuation, prolonged time, and need for manual maneuver. These 3, at least 3 months, the basic scenario we should not forget. And once you have been diagnosing a patient with constipation, we need to look for the risk factors. What is the age of presentation? What is the gender of patient? And apart from that, the status, the education status, the physical activity, a low socioeconomic status. If you're going to say, for example, female gender, they might be having worsening of events up with the constipation because of the main, the sacrococcygeal angle will be low, and all those things to be assessed. And obstetric complications will be there in female gender. All those possibilities as the day progresses, advancing age in which the physiology of defecation is going to tend altered at that point of juncture. You may have worsening of event, and most common etiology that we are not supposed to forget is your drug-induced multiple etiological factors that I'll be taking on the upcoming slide of presentation. Regarding the basic physiology, before to take on that, what is the basic subtypes of constipation? It could be because of your primary, or it could be because of your secondary. Secondary constipation based upon your etiological causes, you need to look into that. Secondary constipation, always a tough to diagnose, and moreover the multiple etiology, and moreover you need to look, it could be because of obstructive multiple causes. And primary constipation, huge list of workup, and who are all the patient you need to work up for this primary constipation. In that, the most common scenario will be your normal transit and sometimes your slow transit, and next to that your defecated disorders, which makes you more complex to diagnose and mixed type. Among this, IBS type C type of presentation also suppose not to get forget, as per your own statement what they are going to mention in that. What is this normal transit constipation? If you're going to look into your transit time, the normal transit should happen within a span of less than 40 hours for your stool to pass on. But what do you mean by slow transit? If it is going to prolong for more than 70 to 75 hours of time to expel your stool, that might be evidence of slow transit constipation. So what do you mean by normal transit constipation? If the stool passes through the colon at a normal rate, it is most common, and patient find it difficult to evacuate the bowel. Even if it is going to pass at a normal rate, there might be difficulty, and it will be overlapping with your IBS-C. The patient most of the time will be having a psychological coexistence factors will be there. And if you want to define your slow transit, young female population, that might be higher risk, and infrequent bowel movements might be there, less than 1 per week, and decreased urgency. The urgency is one factor, the urge to defecation. If your urge to defecation is good, it might be slow to normal transit. But if your urge to defecation, if it is not good, then it might be slow transit. But if your urge to defecation, if it is getting prolonged, and even after that, if it is not going to get expelled, that might be evidence of defecatory dysfunction disorders. So you need to look for all those things: abdominal bloatiness, palpable stool in your colon, along with your colonic smooth muscle dysfunction based upon your various pacemaker, your refluxes, your neurotransmitter activity. If it is going to look into that, your slow transit constipation be identified. Defecated disorders, as I discussed, you are going to spend long time with significant straining, along with manual rectal evacuation usually will be a characteristic clue. Your laxatives definitely is not going to work, so you need to go for biofeedback, another line of modalities of treatment. And many patients will be from childhood. Some patient may have impaired learning of defecation will be there. So what is this defecated disorder? It is due to inadequate rectal or abdominal propulsive force. When you couldn't able to coordinate your abdominal, rectal, and pelvic floor muscles in equal proportion, there might be having a defecated disorder. So your anal relaxation, if it is going to get impaired, your paradoxical external anal sphincter or puborectalis contraction, if it is going to get impaired. So what is going to happen? There might be evidence of defecated disorders to take on. Usually, any rectocele, any weak pelvic floor following obstetric event, if the patient is going to have excessive perineal descent, or if the patient presents to in the background of SRU, solitary rectal ulcer, now might be having evidence of defecatory disorder. And this might be a coexisting presentation of your gastroparesis, like your delayed gastric emptying, along with rectal hypersensitivity, and all those things will be there to take on with the discussion. And functional defecation disorder, as what we are going to look into that, at least the 3 criteria should be there to fulfill. The most abnormal balloon expulsion and impaired rectal evacuation by your imaging modality, and your anorectal pattern, evacuation pattern with your manometry or your EMG, if it tends to be abnormal. In that, at least if you are going to show 2 abnormality for a period, and along with the criteria for presentation for 3 months, and symptom onset at least 6 months prior to diagnosis, has to be there to fulfill this functional defecation disorder. So the qualifying criteria is now described as I discussed with you all. Those 3 major things: balloon expansion, your EMG, and your manometry are supposed to be there. See what is going to happen. The normal defecation, once your stool, once the rectum, if it is going to get impacted, what is going to happen? The puborectalis contraction, your sphincter muscles is going to get relaxed, followed by the defecation is going to get organized. But what is going to happen? The relaxed, once the patient dyssynergic defecation, what are you going to get happen? The prolonged transit time of your colon is going to be there. So what will be the discoordination of your abdominal and rectal muscles? The rectal hyposensitivity, the rectal sensitivity, if it is going to go down, and the sphincter pressure, if it is going to get increased. What is going to happen? The relaxation of resting anal pressure, if it is going to come down, and inadequate abdominal rectal forces. So all these things which will be preponderant for your dyssynergic defecation as per the normal physiology if it is going to get altered. Briefly about the secondary constipation, nothing much to discuss, but the usual list of causes based from your analgesics and antihypertensives and chemotherapeutic as well as antidepressants, anti-Parkinson's, the usual list of causes for medications. That's a separate area to discuss. And common event will be a neurological changes. We are not supposed to forget any metabolic disorders. If your thyroid events, diabetic, and metabolic and electrolyte imbalance, along with that, any neuropathic changes, Sprung's in pediatric age group, as we all know, rectal bounce is one characteristic thing which is going to diagnose this Sprung's, but the patient usually passes a ribbon-like stool-like presentation when you're going to diagnose your Sprung's, in which the patient may deserve a surgical intervention. And apart from that, various list of causes starting from your paraneoplastic, your Parkinsonism, your various eating disorders like bulimia, and the fiber content. So what do you mean by the fiber content? If you're going to see the normal fiber in your diet should be at least 20 to 35 grams, which is predominantly of a soluble fiber, not of insoluble fiber. So if you're going to take a low fiber diet along with high protein, if the patient is going to have any mass lesions in your colon or any pseudo obstruction, Ogilvy syndrome, if it's going to get happen, that might be evidence of the patient to land up with secondary constipation. So in gastroenterology, always blood will be alarming. If the patient is going to have any bleeding anywhere, so look for evidence of gastroenterological blood loss. So alarming picture when you want to diagnose, look for bleeding, weight loss, new onset, anemic symptoms, obstructive pathology. The patient is having evidence of aneurysm and other presentation if it is going to get happen. That shows a characteristic clue that the patient is going to land up with any dangerous alarming punctures. So when you're going to look into the history, see whether the patient is going to have chronic idiopathic or if it is because of secondary causes, look for the proper workup, do a semiological assessment, then only we can be able to diagnose this constipation in a proper way. And detailed history taking, whether the patient is having, what is the frequency pattern, and whether the patient is straining or not, how much of time you're going to spend in your toilet, and what is the shape of the stool based upon your Bristol's classification, and whether the patient is going to do any maneuvers, and whether the ink evacuation based upon your IBS presentation, whether it's complete or incomplete, whether the patient using laxatives, and are we excluding any secondary causes. So this Bristol stool chart, as we are using for the past 2 decades, and if you're going to look into that, type 1, 2, 3 will be considering predominant for constipation, and type 5, 6, 7 will be considering predominant for diarrhea. In Indian scenario, type 1, but Western scenario, you can consider even 1 and 2 for constipation, but 3 not much into Nakun. So this is nothing. You see the shape of the stool. If the stool is going to take on a shape with this, based upon that, you can able to assume in which category the patient is going to present with evidence of constipation predominant or diarrheal predominant IBS-like presentation. So what is the basic clinical approach? As I discussed, any blood, weight loss, any mass anywhere, anemic symptoms, any evidence of obstruction, any evidence of active bleeding or rectal prolapse, that might be evidence to look for, alarming feature for any constipatory patient when you're going to examine. So basic clinical clues for assessing your evacuation, dyssynergic defecation is, so if you're going to spend much of time, your prolonged straining, unusual posturing, your support, and along with your any more fluid, if you're not going to get, expel it out, along with if the patient, even after colectomy, if the patient is going for evidence of constipation, there might be evidence of evacuation disorder being coexistent along with that. So detailed diet history, as I discussed, you need to avoid daily fiber, fluid consumption, all those things, your obstetric history and surgical history, your neurological parameters, drug history, detailed assessment, and one simple thing that most of the physicians, surgeons will not be doing in a routine practice. As a gastroenterologist, I would like to advise you a DRE, a digital rectal examination. So that's supposed to be a separate ASCII for you in your discussion for also the postgraduates you are going to present for exams. So the digital rectal examination do, how are you going to do the inspection as well as your palpation, detailed assessment. You are supposed to do your DRE to diagnose this event of chronic constipation, whether any fecal whether any fecal incontinence is there, or whether the patient is going to have any fecal stool loading in your rectum is there or not. Along all these pointers, you can able to come to the conclusion. So DRE is almost equivalent to your eye resolution anorectal manometry. So DRE we need to do to diagnose based upon this paper what we are going to take in from AGG from 2015 journal. Based upon your rectal examination, how are you going to do? So always if the female patient, make an attendant to stand nearby and expert along with just see, inspect the area, look for, and you need to pull forward and backward to see an anal wedge descent if it is going to be less than 1 or 4 centimeters, and the perineum balloons down during straining, and rectal mucosa partially prolapses through the anal canal. All those things you can identify in your inspection and palpation to see your any tenderness anywhere, any bleeding symptoms, a mucosal prolapse, or any defect in the anterior wall of the rectum suggesting a rectal seal, or if the patient is having a painful perianal condition like a fissure, or look for the sphincter pressure, because the squeezing pressure, everything is expulsion, all those things will be last when you're going to do your palpatory method of palpation in your diagnosing a patient with chronic constipation. So based upon your DRE, the sensitivity and specificity will be almost high, 75 and almost 87. The simple thing which will yield a most complete physical diagnosis to diagnose a patient with chronic constipation. But unfortunately, as I discussed, most of them are not performing. And we need to practice this for all the patients who present to in gastroenterology, OPD, in the background of constipatory disorders. And stool diary for a period of 7 days, we need to assess the level, consistency, straining, Bristol pattern, digital manipulation, as I discussed with you all. And briefly about the case scenario, this young woman who presented to us in the background of constipation for a duration of almost 3 years, but no other medical event being encountered, along with she had been tried with various over-the-counter prescriptions, but the symptoms are not responding. So how are you going to approach? So first we need to map the disease, whether the patient is having any alarming feature, whether it is rapid worsening, any new onset, or any obstructive features, or we need to categorize the patient based upon your slow or a normal transit constipation, or if the patient is going for dyssynergic defecation. Based upon that, the huge list of investigations is there that all. And we should not forget IBS category type C of irritable bowel syndrome type C of presentation. That's also one more important entity will be taken in the differential diagnosis when you're going to manage a patient with chronic idiopathic constipation. And we need to look for the test for systemic disease. Very easy if you're going to suspect a neoplastic, endoscopic investigations and metabolic work of systemic disorder. And you can go for your colonic imaging with CT or MRI, barium minimum, not much of role, but once you're suspecting any obstructive lesion at that point of time may be considered, along with your fecal impaction, limited enema water soluble contrast agent can be used. But you need to be very cautious because chances of obstruction, perforation will be high. You need to be cautious to assess with the barium minimum other study when you're planning to do. But to assess the structural disease, we can try, and imaging of a small bowel can be done if the patient is having evidence of pseudo obstruction, or if you're going to suspect any evidence of obstruction at that point of time. Endoscopy, if the patient is going to land up with alarming events as mentioned by ACG guidelines, we can look into that. So measurement of colonic transit time, that's very important area for us to take on the discussion. How are you going to measure your colonic transit time? There are 3 modalities, one by radio opaque marker, and next one is by wireless motility capsule and by scintigraphy. What is this radio opaque marker? So what is supposed to do? We need to assess the colonic transit time by performing abdominal radiograph at a predetermined time. So we should ask the patient to ingest either a bead or ring, and we need to count the number of retained markers over a period of time. But make sure the patient should be on high fiber diet when you're going to perform, no laxatives or enema prior to that. So what you're going to do, we need to see a single capsule which almost contains 24 markers on day 5. But if the patient is going to return more than 5 markers, it will be considering abnormal. So a single dose of markers is ingested and serial X-rays over a period of 5 days will be obtained until no markers are visible. So this is how we'll be performing this test. So any patient who is going to present with evidence of more than 5 markers all over for a period of time, more than 5 days, that shows evidence that the patient is going to land up with evidence of a slow transit constipation based upon your radio opaque marker study. This is another one investigation, wireless motility capsule being tried, but you can use this. What you're going to do, in which you are going to have a transmitter, your pH sensor. What are you going to do? If you're going to ingest this capsule, it's a non-digestible. It's going to measure your gastric emptying time and small bowel transit time and colonic transit time. So the capsule dimension will be around 26 to 11 mm. So you need to capture the data process and what you're going to do. And this motility capsule by American and European Society, what they mentioned, there is no much of radiation exposure, and you can able to identify in each segment how much of the transit time is going to happen by your gastric, your small bowel, and your colonic period. So the normal transit should be less than 59 hours, but the whole gut transit should be less than 73 hours when you're going to do this wireless motility. In that kind of presentation, if it is going to get prolonged, that shows evidence of slow transit events, which is going to get happen. So this is how the wireless motility based upon your pH, pressure, and temperature reading, you can be able to assess this in your various area of presentation. So the wireless motility, as per this 2016 guidelines, what they mentioned, it's a one-stop shop for most of your GI motility disorder. So you can able to identify with that, and should include the evaluation of a gastroparesis, any small bowel dysmotility, or any slow transit constipation. You can use this WMC to demonstrate a significant beneficial role when you want to diagnose this. What is this colon transit scintigraphy? This is another investigation what we're not supposed to forget. As we all know, scintigraphy, you need to ingest a radio opaque material and followed by using a gamma camera, you need to identify that. So over a period of time. See here, the DTPA coated indium 111 or the technetium 99 along with your egg sandwich and activated chocolate if you're going to ingest. So you need to obtain the images over a period of 2 to 3 days. And you need to assess your colonic transit, what we call this as geometric center, which means it should be less than 2. It should be around 2.7 at 24 hours. So that is a modality to express the scintigraphy values. But in the colonic transit time, if it is going to be less than 1.7, that might show evidence of a slow transit constipation. In this picture, you can able to identify a generalized slow transit. So the slow transit is going to get happen. A functional outlet obstruction is going to be there. But here the colonic inertia, if it is going to come down, all those things we can able to identify with your scintigraphy, what we are going to use, for example, your technetium or DTPA based study. So these are all the basics to assess your colonic transit time. You can use opaque markers, scintigraphy, your wireless capsule, and patient tolerance will be reasonably good for all. Radiation exposure will be less for wireless motility, and expense will be slightly higher for your scintigraphy, will be less than, but standardized, all are validated, reasonable perform based upon the clinical presentation. We need to decide to which test we need to get progress. So what are the various tests to assess the defecation physiology? One by your balloon expulsion is very simple to do. Anorectal manometry, slightly costly issue, but we can make an attempt. Defecography and EMG, but EMG not much of beneficial role nowadays, but balloon expulsion and your defecography with the anorectal manometry can be considered a significant potential role for identifying your defecatory disorders. To diagnose, as I discussed in early presentation, incomplete evacuation of your balloon expulsion and your manometry, imaging, electromyography, the inappropriate contraction if you're going to get identified, and the propulsive forces by your imaging or manometry, if it is not going to be adequate, that shows the defecatory dysfunction has been taken off. So what do you mean by this defecography? Along with that, if there is any evidence of completeness of rectal emptying, it has to be assessed. And next to that, your anorectal angle, your perineal descent. In this area, if there is any complex pathology, for example, if the patient is having evidence of rectocele or any mucosal prolapse, or if the patient is going to present to us in the background of intussusception, at that point of time, defecography, we can consider magnetic resonance defecography will be having when compared to your, this is what the magnetic resonance defecography will be having slightly more potential beneficial effect. So we need to identify the various lines. That's not the area for this discussion, but we should able to identify. We need to see the anorectal junction along with your pelvic floor on straining and defecation. So that is what we are going to assess by resting your squeezing pressure along with your defecatory pattern. And we need to label them as H line or your M line. So what is this H line? The broken white line is a pubococcygeal line, and the solid black line is a M line. So this is the solid black line. What we are going to see is the M line, and this with the broken white line, which is going to be the H line. So based upon that, we can able to identify your various angles and other things which is being there in your defecography. So conventional defecography has an important role in Indian population. We can consider MRI is potential when compared to other things. This is what the squeezing pressure, you're straining, the angle is slightly widening. Apart from that, this is what you're going to assess a severe rectal descent. You can able to identify in this patient, which once the patient is going to land up with this event, so there might be complete evacuation. The descent might be very severe, so you can able to identify this picture. The pelvic floor weakness, you can able to identify once the patient gets strained, your sagging of your sigmoid colon and your diverticulae. This, for example, if the patient is going to have evidence of sigmoid diverticulae, we can able to pick up, and the radiation exposure is one significant side effects, but you can able to identify various anatomic changes like your prolapse and intussusception, and your dynamic changes for your perineum syndrome as well as your dyssynergic defecation also can be able to well assessed. So your defecogram, and next to that your manometry. So anorectal manometry is one most important investigations for your Hirschsprung disease. So what is going to happen? You need to see the reflux pattern. They're based upon your squeeze pressure. So recto and inhibitory reflux, if it is going to be absent, there is high possibility the RAIR, if it is not going to be there, the patient is going to land up with evidence of Hirschsprungs. As we are seeing, adult onset Hirschsprungs also more common nowadays, but rectal sensation, ability of the rectal anal sphincter to relax during straining, all those things you can able to identify using your manometry, and based upon your rectal gradient, rectoanal, say a positive rectoanal gradient should be there for a normal defecation. But if it is not going to be there, impaired reflex that shows evidence of Hirschsprungs, and the defecated disorders for a negative rectoanal gradient being to take on. So a rectoanal gradient be based upon your manometric techniques, we can able to identify your dyssynergia and defecation pattern, all those things. See, if you're going to see this picture, the four main subtypes, what you're going to see in first diagram, what you're going to see, the rectal push is going to be adequate with paradoxical sphincter contraction is going to get happen. But in type 2, the rectal push effect is going to be inadequate with paradoxical sphincter contraction may happen. But in type 3, even with adequate rectal push, but inadequate sphincter contraction will be, sphincter relaxation will be there. But in type 4, all those parameters tends to be inadequate. So that's why I would like to say this how we can able to identify your defecation dyssynergic disorders. And very important thing, what we are not supposed to forget is your bed. So balloon expulsion is your bedside procedure. What you are going to do, you need to inflate a balloon with the warm water of around 50 ml, place into your rectum in the left lateral position. What you're going to do, we need to see the patient is then seated on a commode in privacy and ask the patient to expel the balloon. So what you're going to do, the ability or inability to expel the balloon between a period of 1 to 3 minutes is very important. But in case if the patient finds time more than 2 minutes, which means the balloon is going to get retained for more than 2 minutes, that shows the patient is having defecation dysfunction. So expansion time, if it is going, it's considered always abnormal, and dyssynergia is always going to take on if the patient is going to have a prolonged time of expulsion in the toilet. So the simple modality will be very useful for you to diagnose. It is where the Neurogastromotility Journal. See, as per the paper being quoted by Professor Uday Ghoshal from SGPJ, various guidelines being encountered with this area. So I would like to point out that, see, BET is one bedside investigation able to identify based upon your clinical presentation. Apart from that, so no single investigations can able to assess your anorectal function. Endosonography, anorectal manometry can be tried, but HRM, as we discussed, can be used as one important thing to consider. And moreover, it is going to yield a high resolution solid state methodology, probably in part due to the ability of this technique to more accurately characterize your sphincteric function. So endo-anal ultrasound, you can see if you are going to identify any structural pathology or if you're going to look for any submucosal lesions. At that point of time, you might be having a beneficial role. And in this patient, what you're going to see, once a patient is being diagnosed, the nose stools, the radiopaque marker reveal a slow transit, slow Volga transit. So what you're going to do, you need to try with laxatives, sometimes your newer management, but based upon your history, lifestyle, all those things you need to assess. And one important thing before you're taking on with the discussion is a behavioral treatment. So counsel the patient, do proper training, do proper exercise, weight loss, all those things, diet manipulation, along with you need to chart. Most of the time you need to assume a posture of, rather than using a Western toilet, to use the Indian toilet, because if you're going to use that, the sphincter pressure is going to get well improved. The anorectal angle coordination will be well improved. So followed by your puborectalis contraction will be well improved. That's why the Indian modality of toileting is well recommended for prevention of your defecatory disorders along with the constipation management. So your various trials, what you're going to see, your biofeedback based upon your sham as well as a standard line of care. The feedback therapy definitely is going to have a significant potential role in management. So this is what, before I'm taking on the discussion with your management guidelines, the basics of your AGA 2014. So once you're going to do a physical examination, you're going to identify an etiological focus. So then you need to try your fibers, you need to try your laxatives, but no response. Then the problem comes in the term of gastroenterology. So what you're going to do, you need to do a expulsion test, anorectal manometry at that point of time. And if it is abnormal defecated disorders to be identified, normal means you need to see the colonic transit time based upon your colonic markers, how much it is going to get written. If it is going to be more than 5, it shows significant pointer. So you need to see whether it is slow or normal transit. So normal or slow transit, you can try a laxative. For example, you can try your PEG. PEG is well known polyethylene glycol. If you're going to consider for management, see, it's a long chain polymer. It's mainly based upon your ethylene oxide derivative. So what you're going to do, it is not going to get metabolized by your colonic bacteria. Some points I would like to talk about PEG. So what is going to happen once it is not going to get metabolized by your colonic bacteria, it is going to retain in your stool, and moreover the fluid absorption is going to get enhanced, followed by the osmotic process is going to get well activated in your colon. That's why the polyethylene glycol can be safely considered when you're going to manage a patient with chronic idiopathic constipation. The huge electrolyte formation will be available. One is 3350, one is 4000. So many other things are there for considering a patient with polyethylene glycol when compared to other line of management. And we need to see whether the patient is responding or not responding. If the patient is responding, continue the same. So usual guidelines will be around 8 to 12 weeks of management, followed by, if the patient doesn't show any signs of improvement, as I discussed, we need to go for various studies along with, once a patient, if everything tends to be abnormal, even after that, sometimes the patient may deserve a colectomy or ileorectal anastomosis if the patient is going to show evidence of abnormal manometric procedures. And next to that, your defecated disorder, what is the modality? You need to do the balloon expansion. As I discussed, if it is abnormal, you need to go for MR defecogram. and look for the etiology and do the surgical intervention. But if the patient is not going to have a prominent etiological reason, but the pelvic floor relaxation, if it is going to be abnormal, then you need to go for your biofeedback, suppose biofeedback therapy. But lancet is not much of beneficial role. Apart from that, identification of slow and normal transit, based upon that you need to treat. Endoscopy, alarming features as I discussed, based upon your ASG guidelines. Any surgery, if you're going to plan, if you are suspecting a stricturous lesion or malignant lesion, or if the patient is going to have a deeper biopsy, rectal biopsy, which more than 5 centimeters, if you're going to go deep in for suspicion of your H-Franks, or if the patient is having high evidence of possibility of alarming events at the patient age, if it is going to be more than 50 years, a new onset of presentation, or if the patient is planning for a surgical intervention like your cecostomy or colostomy for severe refractory constipation, and in case if the patient is going to have pseudo obstruction and neurogenic bowel, and all those things may be considered. But the most important thing taking on the management is educate the patient and eliminate the risk factors. And next to that, a fiber good supplementation of 25 to 35 grams per day. Osmotic laxatives like your PEG and other things. And prokinetics, huge number of molecules being tried, newer molecules are there. And finally, a surgical intervention. That's a pyramid you should not forget. But you need to increase your bulk, mainly by your fruits and vegetables, and gastrocolonic reflux, as I told you. Educate the patient, attempt a bowel movement for 5 minutes for 2 times per day, 30 minutes after eating, even if the patient doesn't have any urge. This is what I would like to share with you, a simple paper which has been recently published in 2022 for IBS type C management. So what they have been mentioned, you can consider even for chronic idiopathic constipation. What is the role of chenapenol? What is the role of plecanatide? What is the role of linaclotide, tegaserod, and lubiprostone, your PEG, TCA, and SSRI? What is this chenapenol? It's nothing but a sodium. I don't have much time to take all the slides, but briefly, your chenapenol will be a sodium hydrogen transport exchanger, in which if you're going to take on for that, that might be having evidence of persistent diarrhea, COPD, osteoarthritis, and various type of symptoms being reported. That's why still being a questionable role whether you're going to try chenapenol can be tried or not. But we can use that for a period of time once the patient is showing some sort of response in the management of chronic idiopathic constipation. But plecanatide, linaclotide, these are all I'll be discussing in my upcoming slides. This is what the basic approach. So constipation, you need to categorize fiber intake adequacy, and I'm not very sure whether the slides are well visible. Slow transit means laxatives can be tried, and then your prokinetic agents like your various prokinetics. IBS-C, same modality, you can try for prosecretory agents, and dysfunction disorders you need to go for based upon biofeedback therapy. And nothing was surgical intervention sometimes. So this is what the basic thing, everyone well remember about that. The most important is your osmotic laxatives. Like your PEG, we are not supposed to forget based upon your ethylene oxide mechanisms, in which if it is going to have a inertial role and not going to be inhibited by your colonic bacteria, if it is going to have persistent osmotic water binding, but that might be having your bloatedness, flatulence, abdominal cramps, and rare electrolyte disturbances. Based upon your disimpaction, you can go up to 25 ml in 100 ml, or you can go for colonic enema preparation, or for the maintenance, you can maintain at around 10 ml. But so PEG over a period of time, but longer duration, still more questionable issue. And next to that, management of pain in case of idiopathic constipation or IBS type C of presentation, still a questionable issue to get addressed with PEG and all. So as an overall molecule, polyethylene glycol can be considered based upon your laxatives when you're going to try a patient with this. So various new molecules are there. Briefly to brush up before we are going to wind up, based upon your secretagogues like your lubiprostone and your linaclotide, your plecanatide, so many things. See, if you're going to see your linaclotide and plecanatide based upon your GC receptor, that's nothing but your guanylate cyclase. See, what is this first? First, I will be going with your lubiprostone. It's nothing but your chloride channel activator. So what is going to happen? It's going to increase your chloride secretion in the apical surface of your intestine. So what is going to happen? So once a patient, we can go up to 24 mics, and some patient even we can go up to 8 mics also when you're going to try your lubiprostone. IBS type C, what they're recommending is 8 mics. When you're going to use for chronic idiopathic, we can go up to 24 mics. But the papers for pregnancy and lactation, not much there, no proven beneficial role in hepatic and renal patients. Adverse events like some patients may report dyspnea, that has to be strongly addressed. And linaclotide and plecanatide mainly by your GC activators. What is going to happen? Your CFTR pathway, if it is cystic fibrotic transmembrane regulator pathway, if it is going to get activated, what is going to happen? Your bicarb secretion, your luminal chloride, if it is going to get enhanced, that shows the evidence that the patient is going for a the colonic going for a water transit and all the things that might show that the patient is going to respond to your constipation by this linaclotide. So multiple dosage regimens are there. One is 72, 145, 290. Various papers are there for linaclotide, but 290 mainly for IBS type C and chronic idiopathic 72 as well as 145 can be tried. And plecanatide has already been discussed. 3 milligrams can be tried, but main mechanisms is, as I discussed, your luminal chloride and bicarb secretion, water retention, if it is going to get enhanced, thereby ameliorate your visceral hypersensitivity. So the discussion, the dose is 3 to 6 milligrams. Diarrheal, all events will be a diarrhea. One thing which you're not supposed to forget regarding a chenapror, that one more molecule can be considered, but based upon your COPD or osteoarthritis, that still more need more papers to address your chenapror. Apart from that, opiate antagonists like your methyl naltrexone, albimapone, or naloxegol, so many other molecules can be tried, but these are all out of area for discussion because not much of papers to recommend this molecule. But once you're going to use opioids for a duration of time, at that point of junction, if the patient is going to land up with evidence of constipation, you might consider there's 3 molecules when you're going to manage. Newer drugs, as we are well known, are not new now, but still being well used by most of the physicians as well as surgeons and gastroenterologists. What we recommend is your prucalopride is H2 receptor agonist, as we are well known. What is going to happen if you're going to use 1 milligrams or 2 milligrams of dosage? So it's going to use your gut motility, the contractions, the activation will be going to get enhanced, and your proximal smooth muscles and relaxation of distal smooth muscles, your CAMP mediated colonic chloride secretion is going to get augmented. So we need to have some adverse events like your headache and nausea and diarrhea, but rare concerns like ischemic colitis are there, but still more cases needed to get validated with this thing. But as of now, one reasonably approved molecule when you're going to consider a patient with slow transit constipation, prucalopride can be safely considered. And apart from that, there are so many other molecules, as I discussed, 2 milligrams daily. And this synergic defecation, what is this biofeedback? The one important thing, it's an instrument based upon your operant conditioning technique. So it is having a probe, your ENG, your balloon, all those things will be there. So what they're going to do, they're going to place this device inside your rectum, and your muscles is going to get stimulated. The diaphragmatic stimulation is going to get happen. And based upon your training procedures is going to get stimulated for your dyssynergic defecation. That very few centers in India being experimental with this kind of therapy, but how far you're going to use successfully when you're going to manage, how the physicians, surgeons, how the gastroenterologist is going to accompany the time in the busy OP schedule when you're going to do a biofeedback therapy. These are all is very important questionable indicators to address when you're going to manage a patient with chronic idiopathic constipation. Surgical options, nothing much, colectomy, cecostomy, or sacral nerve stimulation. And briefly about the outlines. And before I'm going to wind up this presentation, the most important thing, what you're not supposed to forget, so fecal microbe, one thing I should mention, not only in the role of alcoholic hepatitis, there might be some papers being beneficial with FMT. Also in antibiotic associated colitis, FMT has been proven beneficial. Now even IBD, there might be considering some papers, but still need more papers to validate. But slow transit constipation, in that some trials are there to consider that. But slow transit constipation, 6 days of FMT. So what is going to happen? The small bowel movements is going to be, all those things is going to get augmented. But It still need more papers to validate, but it has not been fully approved. The data is still research process going on. Apart from that, this is what the initial paper being taken, the chronic constipation by Professor Uday Ghoshal et al. And all those team, what they're going to mention in that the Indian perspective point. There's nothing much to discuss in this. The take-home message before concluding: assessing the patient properly, do good clinical assessment, counsel the patient, look for the etiological trigger, look the precipitating factors, take care of the diet, take care of the nutrition, counsel for weight loss, control the diabetes, treat thyroid in prompt way, assess the patient secondary risk factors, and eliminate the diets or along, diet which contains high proteins, and you need to based upon the balanced fibers around 25 to 35 grams per day has to be well maintained, which is based upon mainly by soluble fibers, and with minimal investigation what are the things is possible. We need to categorize as slow transit or normal transit, or based upon your IBS-C, or based upon your dyssynergic defecation. You need to assess with minimal manipulation, minimal investigations, what are the things can be done. That has to be strongly addressed, and slowly step up and step down pyramid therapy can be addressed when you're going to manage a patient with idiopathic constipation. It's one of the very complex scenario to tackle, and we should not forget, once a patient is having alarming events, refer the patient promptly to the gastroenterologist to overcome all the presentation successfully. With this, I'm happy to rest my presentation, thanking all for patient listening, and if any questions is there, it's my pleasure to take on with that.
Thank you so much, sir. It was really very interesting and in-depth knowledge sharing by you, sir. We really appreciate it. As of now, sir, there are seven questions with me. So in the course of time, whenever if you have any questions, I request our audience to please type them in the chat box. We will take them as we get them. So the first question is, sir, let me open the window first. Yes, sir. So how does sodium picosulfate score over other laxatives?
So see, not only sodium picosulfate score over other laxatives, but sodium picosulfate is being well available in the market. That's a one thing. But along with that, the side effects and electrolyte abnormalities will be slightly less when you're going to use the sodium picosulfate, and almost the taste sensation is not going to be well altered when you're going to use sodium picosulfate. But the dosage regimens when you're going to use sodium picosulfate with the other guidelines will be remaining the same. That's what being considered. Sodium picosulfate, the GI disturbances will be less, and compared to other, that's what the basic laxative when you're going to get concerned.
And so maybe the duration of usage should also be less than 5 days.
Usually the duration of usage when you're going to use sodium picosulfate as a thing, the duration should be at least 7 days to be considered. But some patients, there are papers to try even up to 1 month. There are papers to try for that.
Okay. Thank you, sir. Sir, how do you rate the usefulness of PEG plus Ispagula husk?
This all PEG plus Ispagula husk. So Ispagula husk you can use very well for maintenance therapy. PEG, the main thing is only for this, not only for maintenance, also for disinfection and also for your bowel preparation. And the main thing when you're going to use PEG, that's a long chain polymers, what have been discussed, and the colonic bacteria inactivity will be less. Along with that, there are various electrolyte formulations will be well available. And when you're going to use PEG, the side effects and other adverse events will be slightly less. Ispagula husk, even then, if you're going to consider, there might be evidence of bloatedness, further worsening. Some patients may report evidence of diarrhea and other complications. That's why PEG is slightly overrated when compared to your Ispagula husk.
Okay. So there is one more question regarding the PEG, like how to distinguish the patient, like for example, we have different dosage forms. One is powder PEG and liquid PEG. So which patient population should be suitable for different dosage forms?
Ideally, when you're going to consider any patient with slow transit and other constipated disorders, the ideal liquid preparation will be more recommended rather than going for powder formulation, because once you're going to dissolve, the rapid absorption will be there, the transit time will be rapidly improved. That's why my personal suggestion, even the papers, what they're going to mention, that the liquid formulation is going to have a significant beneficial role when you're going to manage a patient with CIC.
Okay. Sir, your clinical experience with prucalopride? particularly in CIC?
Prucalopride is the second line of molecule after using the basic laxatives like your Esfagala or your PEG, whatever it is available based upon the clinical presentation. But once a patient is going to evidence of diabetic gastroparesis or gastroparetic even in the background of IBS-C or in the background of CIC, at that point of juncture, we can use the prucalopride based upon the age criteria. I can give it a go. Most of the time, I'll be starting with 2 milligrams repeat for a period of around 2 months of duration. I'll be considering, but the less side effects as of now, not much of papers to recommend. But there are some papers to quote the evidence of ischemic colitis. But in my personal experience, we didn't encounter those kind of events when you're going to manage a patient with prucalopride. But the response rate is slightly well augmented. But as the day progresses, whether the tachyphylaxis has been there or not, I'm not very sure when you're going to manage a patient with prucalopride.
And so one more question, like regarding the prucalopride, because sir, the approved indication seems to be in constipation, but have you used in IBS-C patients?
Definitely, we can use in IBS-C patients with prucalopride. As if you are known to look into that, so prucalopride is well proven for HQ agonist. That's why we can able to consider that not only for CIC, also for your IBS type C presentation. That even in ACG 2022 guidelines, prucalopride has shown to have a beneficial role when you're going to manage. But in PEG, what they mentioned in ACG 2222, see the pain events and other things, definitely not much of beneficial role. But apart from that, the event of constipation, chronic idiopathy, when compared to other drugs, reasonably beneficial role that has been significantly addressed. Apart from the newer agents, PEG only has been taken by your ACG 2022. So that's what I want to point out here.
Okay. Sir, you have shown us a lot of newer drugs which are going to come. So regarding that, there's a question that linaclotide or plecanatide, which one is better? What is your view, sir?
So the initial molecule is what has been tried is linaclotide. Now the plecanatide has been taken on the market, but what they were mentioning, the plecanatide will be having a slightly beneficial role as a dose of around 3 milligrams OD. But when you're going to use linaclotide, the dosage regimens have been slightly varying. For example, if you're going to treat your IBS type C, you can go up to 72 to 145. When you're going to treat a patient with chronic idiopathic constipation, we can go up to 290 micrograms. But the side effects profile, not much in the plecanatide when compared to your linaclotide. But even then, not much of major differences are there. You can use, depends upon the patient cost and other things. But as the day progresses, as our experience matters, we'll consider all those pointers properly.
Yeah, maybe there are no direct head-to-head comparative trials for that, sir.
Yeah.
And so one more question about new drug, that is ilobixibat,
Yes.
ileal bile acid transport.
That's when you're going to, that's why I would like to show you a slide for that. The ileal bile acid transporter, the main mechanism, what is going to do that. So
you feel that these drugs will be really helpful, sir?
See, it's going to mainly, see, when you're going to use that, it's going to inhibit your ileal bile acid transporter. What have been discussed, the mode of action is your absorption is going to come down, your increased colonic bile acid is going to get increased amount. So it is going to accelerate your colonic transit. But the phase 2B trial is still going on for your chronic constipation. When are you going to use your elabixibat? So, but why do you want to point out this? Only when you're suspecting evidence of a slow transit modality of constipation. These are all the newer drugs can be tried, but we need more papers to validate all these things to present.
And so secondly, maybe because more bile acids will be remaining, so chances of abdominal pain will also go up, and patient compliance may come.
Possibly.
Okay. Sir, I'll check if we have. Okay, so any scientific study available during the period of pregnancy lactation? We have one question, but there is no name of the molecule mentioned there. So the doctor wanted to know the safety in pregnancy lactation, but the molecule name is not mentioned.
Most of the molecules, second-line drugs, better to avoid in pregnancy and lactation. That's what the personal experience speaks, because there is no much of paper or renal injury or hepatic injury of the patient who's going to have evidence of pregnancy or lactation period. Most of the time, it's better to manage a patient with safe osmotic laxity or something else, but avoid evidence of dehydration. Counseling, look for, along with Esfagala husk, still remaining a potential beneficial role. And PEG can be used to some extent, but you need to be very cautious when you're going to use in pregnant women. But we need more clinical data to look for evidence of second-line drugs in pregnant women.
So that was a question from Dr. Satyabrata Sahu, sir. So thank you, sir, for the question. And sir, just last question, like, where do you place, whenever the plecanatide will come, where do you place this molecule in your selection of the drugs?
Based
So
upon the
that's a
age,
first line or
the
second line.
patient's age, it's going to be less than 65 years of presentation. In the background of long-standing chronic diabetes, in the background of neuropathy and gastroparetic changes, at that point of juncture, if the patient doesn't going to respond with basic first line of molecule, at that point, we can try this plecanatide and other things in which we are going to use for a longer duration of time. For example, your GC activator. And when you're going to use, if the patient's volume of stool, if it is going to be the slow transit process, at that point of juncture is going to be considered well established.
Okay. And so there's last question. So safety of FMT in day-to-day clinical practice.
Safety of FMT, definitely we can well establish, but in my experience in Tamil Nadu, the papers are very, very less, but in for example, in the patient who have been treating for alcoholic hepatitis, we have been having more and more papers for that. But for constipation, always we need to have prolonged contact with your fecal microbiota. So that's one more interesting area to consider. But where are the various areas? How are you going to deploy over there? Those are all the things to be strongly addressed when you're going to manage. But FMT, as of now, is still, we need more papers to document the beneficial role. But you can try as an add-on therapy. But for idiopathic constipation, I don't think we'll be having a significant potential role when you're using so many other molecules without major adverse events.
Okay. So, sir, I'll once again check if there are any more questions. So, Imagica team, do you have any more questions? Okay. So, sir, thank you so much. It was a very much elaborative session, and we really appreciate your time. And we at Lipin are thankful to Dr. Arun for his valuable time for discussing all the aspects of chronic idiopathic constipation, its management approach, and answering all our questions, sir. So, really thankful to you, sir. And we are also thankful to our participants who have joined from different parts of the country and had made this webinar interesting and a successful one. So thank you once again, everyone, from sparing your valuable time from your busy schedule, and have a pleasant evening. Bye-bye.
Thank you, Team Lupin, and thank you to all the delegates for being here. Thank you all the participants. Thank you very much.
Thank you, sir. So with your permission, shall we close this meeting?
Yeah, please.
Yes.
Please
thank
proceed.
you, sir.
Thank
So
you
from
very
here
much
now,
for
I'm
all
ending this meeting.
Thank you, sir. Bye.
Good night. Good night,
Thank you.
sir.
Good night.